Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I'm a Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's webinar, An Introduction to Sarcopenia. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on as the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health, and in the risk reduction and treatment of osteoporosis. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism and is a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises our board and staff on scientific and medical issues. OC provides medically accurate information to patients, healthcare providers, and the public. Our services include programs and support groups, educational webinars, podcasts, digital tools, and resources available at osteoporosis.ca. We are very excited about today's presentation, which will provide information about sarcopenia, what it means for your health, and how sarcopenia relates to bone health. Dr. Shirine Usmani will explain the symptoms it causes, diagnosis, and what you can do about sarcopenia. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. Without further ado, it is my pleasure to welcome our speaker today, Dr. Shirine Usmani. Dr. Usmani completed her undergraduate degree in physiology and pharmacology at Western University before entering the MD PhD program, also at Western. Her PhD focused on musculoskeletal health, specifically understanding molecular mechanisms involved in bone development and osteoarthritis. Dr. Usmani then went on to complete her residency training in internal medicine with a subspecialization in endocrinology at the University of Toronto. She completed a postdoc fellowship through Toronto's Clinician Scientist Training Program with a focus on sarcopenia and genetic regulators of muscle mass. In October of 24, she started a full-time position as a clinician investigator, assistant professor at the University Health Network and the University of Toronto. Her research focuses on clinical and translational research through the UHN Osteoporosis and Metabolic Bone Clinic, and Shirine is also a member of our Scientific Advisory Council. Please join me in welcoming Shirine.
Hey. Thank you so much. And hope everyone can see my presentation. Okay, so thank you for the warm welcome. I feel honored to be able to present today, and hopefully we'll all learn a little bit about sarcopenia. So I just want to say I have no disclosures. And the outline for our presentation today is we'll first start by defining sarcopenia and appreciate why it is important. We'll then identify risk factors for sarcopenia, understand how it's diagnosed, and then we'll also draw connections between sarcopenia and osteoporosis. And then finally, we'll review what can be done to prevent and reverse sarcopenia. So starting with objective 1, sarcopenia can be defined as a progressive skeletal muscle disorder characterized by low muscle mass and strength, as well as poor physical performance. Traditionally, it's been known as age-related loss of muscle mass and function, and it's definitely common in older individuals, but it can occur in some younger individuals as well. So the picture here, it's just showing a person on the left who has what looks like nice, healthy muscle. And you can see compared on the right, this other person has smaller muscles, which may not function as well. Again, I just have some depictions here, illustrations of healthy muscle, which is traditionally thought of as young muscle compared to older or sarcopenic muscle, with young muscle on the top and the older sarcopenic muscle on the bottom. And then to the right, there are these histologic images. So you can see these are cross sections of muscle that are actually from rats. And in the young rats, you can see they have these, each little shape here represents a muscle fiber. And when we look at the sarcopenic muscle on the bottom, you can just tell that these muscle fibers are smaller. So why does sarcopenia matter? It matters because it's associated with a number of very serious adverse health outcomes. So sarcopenia is associated with frailty, with falls, and with fractures, specifically osteoporotic or low trauma fractures, which are very important to me and the patients I see. Sarcopenia can lead to difficulty mobilizing. And for individuals with sarcopenia, they can have difficulty performing activities of daily living. So this would be things like walking, getting out of bed, using the bathroom, preparing food. There's also increased hospitalizations and a greater need for long-term care in individuals with sarcopenia. There's also decreased quality of life as well as increased mortality. And then in addition to these personal costs, there's significant financial burden associated with sarcopenia, and individuals who have it, there's a number of studies showing they have longer and more complicated hospitalizations. So how common is sarcopenia? Well, some estimate that it's present in approximately 20% of people over the age of 50 and 50% of those, 20% of people over the age of 70 and 50% of those over the age of 80. But estimates really vary depending on the definition and diagnostic criteria used. So that definition that I initially presented that has decreased muscle mass, decreased strength, and poor physical performance, is probably one of the most common and most cited definitions. It was developed by the European Working Group on Sarcopenia in Older People. But there are a number of different definitions that do exist. So really global prevalence is probably not known. There is a group called the Global Leadership Initiative in Sarcopenia who are working towards creating an internationally accepted, clear definition. And this will be helpful for clinicians to help diagnose the condition, and it will also be helpful for research. So when we're looking at outcomes, we'll have standards for measuring and comparing different interventions. So what causes this loss of muscle mass and function? Well, one of the most significant things is aging. There is age-associated muscle loss due to a number of factors, and we'll sort of go through what some of those are. And this is similar to osteoporosis, where it's common to see loss of bone density with aging. Sarcopenia caused by thought to be secondary to aging is known as primary sarcopenia, whereas if there is another cause, that can be referred to as secondary sarcopenia. So there are a number of disease states, for example, those associated with chronic inflammation, like cancer, that can have negative effects on muscle. Certain musculoskeletal conditions like osteoarthritis may affect one's mobility, leading to muscle loss. And then also disorders that affect the nerves. If you affect the muscle and how they're innervated, that can also lead to muscle loss. And then other lifestyle factors like inactivity, for example, if someone has limited physical activity or sedentary behavior, or if an individual is bedridden, that can lead to muscle loss. And then malnutrition is also a potential cause. So if individuals have issues absorbing for certain foods or nutrients, like vitamin D, for example, that can contribute to muscle loss. And then conversely, if someone has overnutrition or is obese, sort of the changes that happen in body composition can also have a negative effect on muscle. So I just have a picture here. By no means do I want everyone to remember all of this, but this is just showing a lot of the factors that can contribute to both loss of muscle mass and function. Many of them occur with aging, but some of them can also be accelerated in different disease processes. And I'll just highlight a few. So firstly, changes in hormones and growth factors. So we know that aging is a major risk factor for sarcopenia, and we do see hormonal changes throughout the lifespan. So, most obvious, women who go through menopause have a sudden drop in estrogen levels, and that can have a negative impact on muscle. Similarly, men, testosterone seems to decline although like more gradually throughout the lifespan. But testosterone levels may also be lowered, for example, in individuals taking medications for prostate cancer. Another really important hormone that sort of decreases throughout the lifespan is growth hormone and IGF-1. IGF-1 in particular has a lot of significant roles in muscle in terms of muscle growth, mediating responses to exercise, and also being involved in repair. To just highlight a few more sort of mechanisms, satellite cells, so these are the stem cells within muscle. With aging, we can lose the number of stem cells and they can also become more dysfunctional, impacting muscle repair. And then mitochondrial dysfunction. So this comes up a lot. Mitochondria, these are really the powerhouse of our cells, and they produce energy for the cells. But as we age, again, the mitochondria can become more dysfunctional. So I have a couple of pop quizzes throughout the presentation just to keep everybody on their toes. Um, so the first question here is, at what age do we start to lose muscle? In our 30s, 40s, 50s, or 60s? Give you a few seconds to think about that. And the answer may be surprising, but it's in our 30s. So I would assume that most people attending the seminar today may already be experiencing some muscle loss, including myself. So muscle mass is lost at a rate of 3 to 8% per decade after the age of 30. The loss occurs more rapidly after age 60, and muscle function is lost more rapidly than mass. It's estimated that by age 80, approximately 40% of the vastus lateralis has been lost. So this is the muscle highlighted in red here. It's part of the quadriceps muscle. It's a major muscle group of the lower limbs. And that's important because losing muscle mass in the vastus lateralis has been associated with increased risk of falls and fractures. So why is muscle so important? I think muscle is very important, but it may not be something that people think about every day. We are all likely familiar with the structural functions of muscle. So, for example, muscle is essential for movement and exercise, for balance and maintaining posture. And this is very helpful in preventing those falls and fractures. And it's also important for strength, which allows us to carry out our daily activities. But muscle also has a number of metabolic functions. So actually, the human body in a healthy person is composed by about 40% total body weight muscle. And muscle has a number of roles. So it's a major storage site for proteins and glucose, and these can be used as energy stores. It also has roles in fatty acid oxidation and heat generation. And then more recently, it's really been identified that muscle is an endocrine organ. So muscle has the ability to make these myokines, which are little signaling molecules that get sent out and then can affect basically any other tissue in the body, including bone. So there's even hormones or little myokines that are secreted from muscle that can help healing after a fracture. So given all of this, I have another little pop quiz here, which is, in addition to falls and fractures, sarcopenia is associated with A, diabetes, B, cardiovascular disease, C, cognitive impairment, D, death, or E, all of the above. So after that slide talking about the importance of muscle and how it's an an endocrine organ, how it communicates with essentially every other tissue in the body? The answer, not surprisingly, is E, all of the above. As an endocrinologist, I see a lot of patients with diabetes as well as bone disease. And I'm always talking about the importance of exercise and skeletal muscle. So just to speak about that for a minute, skeletal muscle is really important after we have a meal. It's the organ that takes up and stores the majority of carbohydrate that our body doesn't need right away. So you can think if you have lower muscle mass or dysfunctional muscle, the body's not going to be able to take up and store glucose, and there's less just circulating in our system, which can lead to diabetes. And then it creates a little bit of a vicious cycle where there's more circulating, high blood sugar that can then go on and cause more harm to the muscle. So all of this to say, muscle is really important and is associated with a number of comorbidities. One very large meta-analysis looked, so that's basically a study that tries to compile the results from lots of other studies. They included about 17,000 individuals with disease, chronic diseases, and about 22,000 controls. And what they found is that sarcopenia is really highly prevalent in cardiovascular disease, diabetes, dementia, and respiratory or lung diseases. So sarcopenia was present in about 31% of patients with cardiovascular disease, 26% of patients with dementia, 31% of patients with diabetes, and 26% of patients with respiratory diseases. So this is really significant. While it doesn't necessarily show causation, there are some mechanisms that are common to sarcopenia as well as chronic diseases, but there is a lot of crosstalk between muscle and all the other tissues. So potentially there is some causation associated. Sarcopenia is also related to longevity and mortality. So studies have shown that greater muscle mass and strength is associated with increased longevity. Even something as simple as a grip strength test has been shown to be associated with longer lifespan, the better that you do. And then there was one study that looked at frailty, which sarcopenia is a component of frailty, in critically ill or ICU patients. And they found that in-hospital mortality was higher in frail patients compared to those without frailty, so 32 versus 16%. And 1-year mortality was also higher in the frail patients, 48% versus 25%. So essentially double. So I hope I've shown you, explained what sarcopenia is. So loss of muscle mass, muscle function, and poor physical performance. And it's important because it affects, almost every system in the body and as well as mortality. So now we're going to talk about some risk factors for sarcopenia. One of the major risk factors, as we've already identified, is aging. So this is just a graph that's showing muscle strength along the y-axis and age along the x-axis. And the lines indicate muscle strength throughout the lifespan. So as you can see, this is actually really similar to bone, where we acquire, peak muscle mass and muscle strength, just like we acquire peak bone mass early in life, around the 20s to 30s. And then in adult life, there is a trend towards losing muscle mass and strength. The two lines here just depict that there is variation among individuals. And then there is a threshold below which physical performance is affected, and another threshold below which disability occurs. And I will just note, so this graph is indicating muscle strength, but it also could represent muscle mass. There are also a number of changes that happen within the muscle itself with aging. So the muscle fiber number and diameter decrease. So we already saw that with these images from the young and old rats here, that the diameter of the muscle fibers decrease with aging. There's a decrease in type 2 fibers. So these are the fast twitch or the muscle fibers that are used when we need like a boost of power, and they're important for quick movements. The mitochondria, those powerhouses of the cell, can become dysfunctional and generate reactive oxygen species that further damage muscle. There's also reduced capacity for repair, partially mediated by decreases in hormones like IGF-1, and reduced satellite cells, or those stem cells within the muscle. We can also get infiltration of other non-contractile tissue, like connective tissue and fat deposition within muscle. And then changes to nerves with aging can also affect the muscles. We also experience changes in general to body composition with aging that can have some negative impacts. So this is actually these are interesting images here just to orient you. This is like a slice through an individual's abdomen. So the back is at the bottom, and that really bright spot is the vertebrae. And then on top, you have the abdomen. So what we have here is we have two individuals who have the exact same waist circumference. So looking at them from the outside, they might look a similar size. On the left, we have a young person who is 37, and on the right, we have an older person who is 82. What you can see here is this sort of gray area right below the surface is the subcutaneous fat. So the younger person has quite a bit more subcutaneous fat. But if we look at the older person, they have a lot more of that gray in the middle around their vital organs. So this is known as visceral fat. It's metabolically dangerous and is associated with low-grade chronic inflammation. Within muscle itself, we can also see changes in composition. So these are thighs, and again, this is just a cross section. These are a young and old individual. Here they have the same body mass index. So that's just weight divided by height. So they may appear similar, but they actually have quite a difference in the distribution of muscle and fat. So in the younger person on the left, the white represents subcutaneous fat around the perimeter. So they have more subcutaneous fat. Whereas if we look at the older individual in their thighs, they have less subcutaneous fat and more marbling throughout. So there's actually more fat between and within muscle. And this is significant because fat can have a negative effect on muscle when there is too much, or if it's in the context of obesity. So what we have here is on the left, sort of a healthy muscle, healthy fat, and on the right, it's sort of showing this metabolically challenged tissue where we have fat deposits within and between the muscles. And this can lead to chronic inflammation, decreased ability of the muscle to repair, an increase in fibrosis, so an increase in this connective tissue that's not functional, does not help our muscle. And it can lead to problems like diabetes and affect mobility, leading to issues like arthritis. Okay, so that has sort of showed that muscle changes throughout the lifespan, but we also have changes in body composition with aging that can negatively affect muscle. So for the next pop quiz, I just want to ask, which of the following is not considered a risk factor for sarcopenia? Aging, inflammation, high protein diet, or inactivity? And the answer is high protein diet. The rest are all associated with or could be potential risk factors for sarcopenia. So I just have a nice image here from a review paper that is outlining the risk factors for sarcopenia. Some of them we touched a little bit on when we discussed the etiology of sarcopenia. But the one thing I want you to note is that some of them we have no control over. So for example, aging or our genetics, potentially neurologic disorders. We may have some ability to control certain chronic diseases like diabetes, for example. If we type 2 diabetes, if we can improve hemoglobin A1C with diet and exercise. But there are a number of modifiable risk factors, mainly diet, exercise, and we have, to some extent, the ability to modify our body composition through changes with diet and exercise. Okay, so I hope we've identified some risk factors for sarcopenia, some non-modifiable ones like aging and genetics, and other modifiable ones like diet and exercise. And now we're going to move on to understand how sarcopenia is diagnosed. So these again are the components of sarcopenia: low muscle strength, low muscle quantity or quality, which can result in poor physical performance. So essentially, if someone has low muscle strength, we can say they probably have sarcopenia. If someone has, if we confirm by some sort of imaging or techniques like bioelectric impedance, we can confirm the diagnosis of sarcopenia. And then the physical performance tests really tell us about the severity of sarcopenia. And full disclosure, sarcopenia is an underdiagnosed condition, partially because the criteria are not clear or definitions are variable. But really, personally, I don't remember hearing much about sarcopenia in med school or residency. But it is something I think about all the time now when I see my osteoporosis patients in clinic. Okay, so another pop quiz. How do we diagnose sarcopenia? A, based on history. B, based on grip strength. C, DEXA, which is dual X-ray absorptiometry of the muscles. It's an imaging technique of the muscles. D, gait speed. Or E, all of the above. So as you can guess, it's a diagnosis that's made based on multiple factors. So all of the above is correct. This is a diagnosis algorithm for sarcopenia. This one was actually made by the same group that came up with the definition I presented in the beginning, the European Working Group on Sarcopenia in Older Persons. And the reason for this algorithm is to try and, streamline how sarcopenia is diagnosed, and to also streamline the criteria and the cutoffs for specific tests. So the first step is to find cases, find people who may have sarcopenia. In practice, we do this a lot through clinical suspicion. So if we have an individual who has a history of falls, who appears frail, who may have a history of fractures, we might worry that they have sarcopenia. There's also a questionnaire that can be done called SARC-F. So SARC-F is the screening test, and it's an acronym. So stands for strength, assistance in walking, rise from chair, climb stairs, and falls. And the questions are, how much difficulty do you have lifting 10 pounds? How much difficulty do you have walking across a room? How much difficulty do you have transferring from a bed or chair? How much difficulty do you have climbing a flight of 10 stairs? And how many times have you fallen in the past year? So you can see based on the answer, a different score is applied, and anything equal to or greater than 4 is concerning for sarcopenia, and strength testing should then be performed. So moving on to the next step, if the screening was positive, we move on to assessing. So there are different tests that we can use. One is grip strength, and one is the chair stand test, which I will just show you now. Grip strength, as we said, there's pretty good evidence that it's associated with lower all-cause mortality, lower cardiovascular mortality, and lower risk of disability. There's a number of different tools that can be used. There's digital grip strength meters nowadays, and the cutoffs vary between males and females. So it's a very simple test that you can do, in a few seconds. The other test is a chair stand test. So essentially, an individual would sit on a chair with their arms crossed across their chest, and they would have to rise from the chair without using their arms. And you would see how many times they could do this in 15 seconds. A normal test is to be able to do it at least 5 times in the 15 seconds. If it's less than that, it's concerning for muscle weakness. So if either of those tests show low strength, then you can move on to confirming the diagnosis. But if someone has, if you have a clinical suspicion or they have a positive questionnaire and they have low strength, this person probably has sarcopenia. And in our healthcare system, we don't routinely image muscle for sarcopenia because that would be enough, the probable sarcopenia, to recommend treatments. For research purposes and for studies where you're looking at the outcomes and you want to compare treatments with each other, having a confirmation or some standardized way to confirm sarcopenia would be required. So there's different modalities that can be used, different imaging modalities, DEXA, CT, MRI, and also that bioelectrical impedance that we talked about. That's essentially where a low electric current goes through the body, and depending on the speed, it can estimate how much fat and muscle there is. So I'm just showing some pictures from a DEXA scan here. So on the left, we have an older person who appears overweight. And the colors represent different tissues. So yellow represents fat, the sort of blue represents bone, and then this sort of red-purple represents muscle. On the right, we have a 40-year-old woman who does not appear obese. And as you can tell, relative to the fat, there is more of that kind of red color and more of this lean muscle mass. So you can calculate something called an appendicular lean muscle index or appendicular smooth muscle index, which basically takes the proportion of lean tissue divided by height. Okay, and then once sarcopenia is confirmed, we would assess severity with these physical performance tests. Quite frankly, because we usually skip the confirmation stage in clinical practice, we often do tests like this, even if we just have clinical suspicion and are trying to assess our patients for a risk of falls and things like that. So in terms of these tests, there's a very simple one, which is called the gait speed test. Someone walks 4 meters at a normal pace, and they should be walking at least 0.8 meters per second. There's also something called the short physical performance battery that combines balance, gait speed, and the chair stand test. A score is given for their performance on each of these tests, and then the overall score tells us the likelihood that they have good or poor performance. And then this is one that is pretty easy and we commonly do, and it combines a number of things, the timed up and go. So it starts with a person in the seated position. They have to rise from their chair, walk 3 meters, turn around, go back and sit down. So this should normally be done in less than 20 seconds. But as you can see, it integrates a number of things, changing position, turning, and walking. So by no means does anybody have to memorize these, but this is just from that European working group on sarcopenia in older persons. And they've tried to standardize the cutoff points for these different tests to sort of unify our assessment of sarcopenia. Okay, so we've kind of gone over how to diagnose sarcopenia. We first have to identify patients that are at risk, assess their strength. We may or may not use some form of imaging or bioelectrical impedance to look at the muscle quantity, quality, and then we can assess severity with physical performance tests. So now we'll move on and we'll talk about how sarcopenia relates to osteoporosis. So muscle and bone loss are both common with aging, as we've already discussed. If someone has a diagnosis of 2 conditions, so they could be diagnosed with osteoporosis either based on low T-scores on their bone density scan or based clinically if they've had fragility fractures, and they have a diagnosis of sarcopenia, they could have a combination of the two. So there's these phrases that have been made, sarcoporosis or osteosarcopenia, to describe when people have both conditions together. And it's sort of significant to identify this because individuals with osteosarcopenia have a higher risk of falls, fragility fractures, institutionalization, and mortality than either osteoporosis or sarcopenia alone. There are common mechanisms that can lead to both bone and muscle loss, including aging, inflammation, hormonal changes, inactivity, and malnutrition, as we've already discussed. And there's also this concept of the bone muscle unit that has a lot of crosstalk. So I always tell my patients in osteoporosis clinic, when I talk about resistance training, that there is a lot of communication between the muscle and bone. And by helping to have healthy muscle, you can actually help support your bones. So I just have an image here. Again, you don't need to worry about all of the little growth factors and cytokines listed here, but it's just to symbolize that muscle and bone talk to each other. And as I already alluded to before, some of the signaling molecules made from muscle can go and help with healing after a fracture. Some of the growth factors made in bone can help to support muscle growth and repair. So they really work nicely together. But if you have compromised muscle and compromised bone, as it's depicting here, the low muscle mass could increase your risk of falls. The low bone strength also makes you more vulnerable. And if you have both osteoporosis and sarcopenia, this can increase the risk of fractures, disability, and mortality. Older adults with sarcopenia have about a 1.5 to 2-fold higher risk of falls than those without sarcopenia. These numbers vary a little bit in the literature depending on the studies, but it's about that range. There is also a higher risk of fragile falls. So these are falls that can happen when someone, when their legs sort of give out or when they're changing positions. It's not necessarily a trip and fall. And they also have a higher risk of falls-related injuries, including hip fractures. In one study done in elderly patients, 1-year mortality for hip fracture was highest in patients who had osteoporosis and sarcopenia at 15% compared to patients with just osteoporosis or just sarcopenia. So I hope I've showed here that, osteoporosis and sarcopenia can often coexist together. There are many common risk factors, but one of the positive things about it is that treatments often overlap. So we do have a lot of really good resources for conservative management of osteoporosis, which also help our muscles. So next, we're going to review what can be done to prevent and reverse sarcopenia. Okay, so another pop quiz. What is true in terms of sarcopenia treatment? A, there are approved medications. B, exercise improves strength but not function. C, treatment approaches are multimodal. Or D, endurance exercises are not helpful, but resistance exercises are. Okay, so like many things in medicine, treatment approaches are multimodal. So what can we do about sarcopenia? It's a multidisciplinary approach, and it can be a personalized approach. So I'm a physician, I can diagnose things, I can treat certain things, but I am not an exercise physiologist. I'm not, a personal trainer. I don't have that. There are many other people who have more expertise in exercise than me. So it really takes a team. As well, dietitians can be very helpful to this management. So yes, what can we do? We'll talk about exercise strategies, diet strategies, vitamin D and other supplements. And then I'll also briefly touch on medications that are under investigation. Okay, so resistance training or strength training is the most effective exercise strategy to improve muscle strength in older individuals. It's really important to be consistent, so to do the strength training 2 to 3 times per week, and it's important to be progressive. You don't want to be using light weights all the time and not challenging yourself. Muscles actually grow by sort of pushing how much weight you can do. You want to target major muscle groups, and these types of exercise include things like free weights, resistance bands, machines at the gym. But you can also start with no equipment using your body's own weight, doing things like squats or lunges. Studies have shown that resistance training combined with aerobic training or nutritional supplements like calcium and vitamin D may have better results than resistance training alone. But there are multiple studies, and it seems like most of the benefit comes from the resistance training itself. And this is, great for us. It overlaps nicely with recommendations from Osteoporosis Canada. So this is a picture from their Too Fit to Fall or Fracture pamphlet or handout, available on the osteoporosis website. It's just osteoporosis.ca, easy to remember. But yes, so they're recommending for bone health, strength training 2 or more times per week with increased difficulty of exercise over time. And they highlight here that it should feel like hard work. If you're going to be building muscle, you're going to feel it. And then in terms of strengthening, there's a lot of different exercises you can do, as they have some outlined here: lunges, side plank, and there's lots listed as well. Now, aerobic training, some people may wonder if there is any role for it, but in sarcopenia, but there is. So some studies have shown that aerobic exercise can lead to improvements in body fat mass, that visceral adiposity that we saw in those images of young compared to old individuals. And aerobic exercise can help to maintain skeletal muscle mass. So you're not necessarily going to gain more muscle from aerobic training alone, but it can help maintain. And then thirdly, balance exercises. Studies have shown that balance exercises can help improve physical performance. And then when combined with resistance and aerobic training, there's greater benefit to quality of life. And as we know, balance exercises can reduce the risk of falls and help with function in daily activities. So they are critical. And again, balance exercises are endorsed by Osteoporosis Canada, and again, overlap really nicely with the treatment of sarcopenia. So you may want a personalized exercise strategy. There are people who are very highly trained to help develop exercise programs for individuals, depending on their abilities, previous injuries, comorbidities, and goals. So there are physiotherapists, exercise physiologists, kinesiologists, personal trainers, and we do have some resources through the Osteoporosis Canada website as well. We have a link to BoneFit, which I'll talk about, as well as a video series online. So BoneFit can link you with a trained professional who's been, as it says, specifically trained to provide safe, effective, and evidence-based exercises for clients with osteoporosis. And as we know, a lot of the exercises for osteoporosis, whether it's strength training or balance exercises, are also going to provide benefit for sarcopenia. The one challenge with exercise and working with individuals is that it's not necessarily covered. In Ontario, OHIP doesn't, there are a few like OHIP covered physiotherapists, but many things are not covered. So I've had some patients who've reached out to BoneFit and they've had, 1 or 2 sessions, and they've just had somebody, because that's what they could afford, had somebody review their exercise routine, make suggestions about how it could be done more safely and how it could be more effective in building muscle mass. And, that was very helpful and didn't break the bank. On the Osteoporosis Canada website as well, we also have a whole video series on exercise. So again, if somebody is not able to afford one of these other options, Dr. Laura Giangregorio, she's an exercise physiologist from Waterloo, and there are about 25 different videos in the series that you can look at from home. They provide education, but also instruction on how to do various exercises related to strength training and balance and how to do them safely. Now, what about diet and supplements? So one thing that there is evidence for is that low-calorie diets can actually be associated with loss of muscle mass in older obese adults. So again, this will be an individualized approach, but for more people, if you are just cutting down on calories, that may not be the most beneficial thing for your muscles. Instead, it's important to eat a healthy foods that are high in things like protein. So studies have shown that to maintain and regain muscle mass and function in the long term in older people, it's recommended that they have dietary protein in the 1 to 1.2 kilogram per, grams per kilogram body weight range. If individuals are malnourished, they may need even more. And then there are a number of protein supplements that have been looked at, like whey protein, leucine, which is an essential amino acid, or beta-hydroxy beta-methylbutyrate, which is a metabolite of leucine. There is evidence that these may help with strength and muscle mass in certain studies, but it seems like there's more of a limited effect on physical performance. And even though there are multiple studies, the evidence shows that high protein diets or protein supplements are most effective when used in combination with resistance training. So really that resistance strength training is the foundation of management of sarcopenia. In terms of other supplements, vitamin D is important. We certainly want to correct it if there is a deficiency. There's evidence that it may improve muscle strength and physical performance. It has also been shown to be associated with decreased falls risk. Again, this overlaps with our recommendation for vitamin D for the management of osteoporosis. There's limited evidence for other things like calcium or magnesium, but directly for sarcopenia, but we know that by helping our bones, we can help support our muscles. So it's still good to make sure you're getting adequate dietary intake of things like calcium and magnesium. And then I just added here creatine. I feel like it's something that has come up a lot on social media and podcasts particularly. So it's an organic compound synthesized from amino acids. It helps to generate ATP during high energy demands. And there are studies showing that it may increase muscle strength and mass as well as function. Again, the effects are most significant when it's used in resistance training. So that resistance training is going to do the majority of the work. And then it's also important to note, though, that many of these studies are done in healthy older people or pre-sarcopenic adults. So it's unclear what the role is in severe sarcopenia. So again, not something that everyone should do, but it might be worth talking about with your healthcare provider if you are interested. Again, a lot of these nutrition recommendations overlap with Osteoporosis Canada's guidelines for nutrition. So this is just showing the Osteoporosis Canada website and the section on what to eat. And there are multiple sort of links to different things like calcium, vitamin D, protein, magnesium, and vitamin K. And specifically for sarcopenia, looking at vitamin D and protein would be important. And then there's also this great tool, which I feel like I tell patients about every time I see a new patient, which is the Osteoporosis Canada Nutrient Calculator. So for all of those elements, calcium, vitamin D, protein, magnesium, vitamin K, you can use the nutrient calculator to see if your diet is sufficient. So I'll just briefly touch on caveats related to treatment of sarcopenia. The definition of sarcopenia and outcome measures used varies. So there's a lot of meta-analyses where they'll look at multiple studies looking at supplements, but a lot of the individual studies vary in terms of how they were conducted. So they're difficult to compare. Many are not long-term. So they don't necessarily look at whether these interventions are associated with a change in those outcomes, those adverse outcomes of sarcopenia. Some patients with comorbidities may not be able to tolerate the intervention. So for example, individuals with renal failure should not be on a high protein diet necessarily. It could actually be harmful. And then aging muscle also develops anabolic resistance, meaning that it doesn't quite respond the same way to stimulus like protein or strength training compared to young muscle. So it's important if you're looking at studies that you actually look at the age group that it was done in and see whether it's relevant for you. So then finally, we'll just say there's a lot of ongoing research. We talked about how hormones like estrogen and testosterone, also DHEA decline and growth hormone decline with aging. So there's some studies looking at hormone replacement therapy, which may have modest benefits with estrogen or testosterone in postmenopausal women. Because testosterone itself can have a number of negative side effects, like increasing your cardiovascular risk, causing high hemoglobin, or causing enlarged prostate in men, people are looking at what's called selective androgen receptor modulators that can affect receptors specifically in certain tissues, like muscle. There's also myostatin inhibitors. So myostatin is actually a signaling molecule that can halt the growth of muscles. So if you inhibit myostatin, potentially it could cause more growth of muscle. And then ghrelin is something that affects our appetite and intake, and studies are looking at how that might affect muscle mass and function. And these are just a few. So this last slide, so this is a review paper from 2023, which actually tried to depict all of the clinical trials and at their different phases going on to see how we can treat sarcopenia. Many of the mechanisms relate to things that we already talked about: myostatin, growth hormone, IGF-1, mitochondria, androgens. But there is a lot of work being done, but to date, there are no medications approved for the treatment. So there's no pill, no injection that you can take for sarcopenia specifically. Okay, so just to summarize, sarcopenia is a muscle disorder characterized by loss of muscle mass and strength and poor physical performance. It has a number of adverse outcomes, including falls, fractures, and mortality. So it's a significant thing. There are many risk factors, some that are non-modifiable, like aging and genetics and hormonal changes, and there are some that are modifiable, like activity and diet. Sarcopenia diagnosis involves measuring muscle strength, muscle mass, and performance. And sarcopenia and osteoporosis commonly occur together. They may share many risk factors as well as treatments. And then finally, sarcopenia can potentially be prevented or mitigated and potentially reversed with exercise, the mainstay of which is resistance training, but also a variety of exercises like aerobic and balance exercises are also important. Adequate or high protein diet and appropriate supplementation where needed, such as vitamin D. And then research is ongoing about these other treatments. So that's all I had, but thank you so much. And Kerry, I'm not sure if you have any questions for me.
Well, that was just great, Shirine. You provided so much information. It was great. We do have some questions, so we have a few minutes. We'll get to a few. I know you've covered these, but I think that they're worth repeating just to emphasize the point. Can you prevent sarcopenia?
Yeah. So I think it's something that we can't necessarily prevent 100%, but I think we can try to mitigate the losses, similar to osteoporosis. So, by we just being aware that we start to lose muscle mass in our 30s. So, the earlier the better to get into a good exercise routine that incorporates resistance training to ensure that you're eating a healthy diet and you're getting adequate protein intake. I don't think there's any studies that have really been done in the long term to show what degree it can be prevented. But certainly, if you compare someone who doesn't do any of these interventions versus somebody who does, I would expect the person who does to maintain more muscle mass throughout the lifespan.
Okay. This is a sort of the next question. Can you reverse sarcopenia with diet and strength training?
I think to a certain extent, again, probably not 100%, but certainly there are lots of studies, although they're done in the shorter term. A lot of the studies look at exercise training, like intensive resistance training, progressive resistance training for 12 to 20 weeks, and you can gain muscle mass and see better outcomes on performance. The studies vary quite a bit, but there are multiple studies that show particularly exercise intervention and exercise combined with dietary protein or protein supplements can reverse sarcopenia to a certain degree.
Okay. Can you explain the difference between muscle mass and muscle?
Between muscle mass.
Yes. Is there a difference between muscle mass and muscle, or are they the same?
I think it depends a little bit about what you're talking about, but muscle mass is just like the physical amount of muscle that there is. Um, oh, and there's different types of muscle too. So, we're talking about skeletal muscle. There's also, smooth muscle, cardiac muscle. But when we're talking about muscle mass in the context of sarcopenia, we're really talking about that skeletal muscle.
Okay. The next question. How do you know if you've lost muscle strength? Is there an easy way? I know you went through some tests and diagnoses, but
Yeah.
the average person, can they tell if they're losing muscle?
Um, you might feel it. Like we don't have a standardized way. So for example, with DEXA scans for bone density, we compare your bone density to that of a young, healthy person at peak bone mass, and then you can trend over time if your T scores are declining, that you're losing bone mass or bone density. We don't really have something similar that is done commonly in clinical practice to really track that. You could look at things like grip strength over time. That's more for function, not really mass. But we don't really use these like the imaging techniques. They're costly, and we don't use them routinely for following sarcopenia.
Okay. Just you mentioned grip strength. One of the questions that we received was, is it possible to increase your grip strength?
For sure. Yeah. Yeah.
Okay. We'll just do a couple more questions. I know we're getting close to 3 o'clock. Um, is there a safe way to build muscle after a fracture?
Yeah. So that's a good question. I think that really it would involve, again, a multidisciplinary team. So, I'm not an orthopedic surgeon. If it's a major fracture, like a hip fracture, um, it's everyone is involved, right? Like physiotherapy, potentially rehab. Um, you'll have to listen to the orthopedic surgeon and what they recommend in terms of weight bearing and how long to be not weight bearing. So depending on the type of fracture, there may be some muscle loss associated, uh, especially if that limb is immobilized for a certain amount of time, or if you're not allowed to weight bear on it. So I think it's, again, like kind of a multimodal approach. And in general, I think recommendations are to start slow and progressively increase.
Okay. We have time for one last question. Is there a particular muscle that's easier to lose mass in? Are the upper extremities is it easier to lose muscle up in the upper extremities or the lower?
That's a good question. I don't know if I know the exact answer to that question, but I think the vastus lateralis, as we talked about, is one that's particularly at high risk of losing significantly over the lifespan. Um, but I'd have to look into that about, women and men, and where, because women tend to have, like, even throughout the lifespan, lower grip strength than men. That's why there's different cutoffs. But I'm not too sure. I'll have to look that one up. And just to mention something about the grip strength, that question, can you improve it? I just want to highlight that, grip strength is just a marker of your muscle strength. So there are certain people with, medical conditions like rheumatoid arthritis and things like that. If you have poor grip strength because of that, that's not really what we're saying, that your lifespan is limited because your grip strength is poor because of a different illness. It's just one of the markers, but like we said, there's lots of tests to um, measure your strength, and likely the physical performance tests are probably the most important.
Okay, there's lots of questions, but we don't have time, so I just want to say thank you to Shirine. This was just absolutely wonderful. We're getting comments that this is the best webinar they've heard,
Oh.
and thank you so much. Um, for more information about osteoporosis, everyone, please visit our website at osteoporosis.ca. Our website includes many, many tools, including the nutrient calculator that Shirine mentioned earlier. We have podcasts, we have quizzes, and we do have a repository of past webinars. This webinar will be in that repository in, I think it's 24 hours. Our next webinar will be on Thursday, and it will actually be a cooking demonstration on stuffed turkey breast. And we do have a few other events coming up, as you can see on our slide here. And remember to register for these events. We're going to be at the National Menopause Show on October 18th and 19th. We have another webinar coming up on the November the 6th, and a few other things. So Please check your email for those events. And I'm also asked to let you know that due to the postal strike, if you are planning to make a donation to Osteoporosis Canada, please use our secure online donation page found at osteoporosis.ca, or give our office a call. Somebody will be there to answer your call. And thank you so much in advance for your donation. And finally, I want to say thank you to all of you for joining us today. I hope you join us again soon, and wishing you a great rest of your day. Thanks again.